I welcome you to today. I think it's a very important meeting because today we are going to talk about the new pattern of examination. And though the college is still not clear as in instruction as to what is going to happen, but our impression is that it is going to be more of short case presentations. Before I start, I would just like to bring in front of you three important things. जब भी किसी कैंडिडेट की असेसमेंट हो रही होती है तो एग्जामिनर तीन चीजें देख रहे होते हैं इन द एग्जाम. It is knowledge, it is knowledge, skill, and it is knowledge, skill, and attitude. So, in any examination that is being conducted, whether it is RCOT exam, whether it is FCPS exam, all these three domains are going to be tested. Now, the thing is that how is the College of Physician and Surgeon going to ensure that these three domains are tested from the point of view of the perspective of the candidates? So, पहली बात तो ये है कि जब आप लोगों ने MCQ का एग्जाम दिया, तो depending on the MCQ type, they can test your knowledge and interpretation of knowledge in the MCQ exam. So, if the MCQ is one best type, most of the time, the basic knowledge can be assessed, but interpretation of knowledge to be understood has to be a different kind of MCQ in which you pick and choose what is the best option available. Now, coming to our part of the clinical examination, now as CPSP has already said that they are not going to be long cases. So it means that in all probability, the live patients or the actual patients probably will not be there as a part of the examination. Now, then the question arises that how is history taking? Clinical evaluation going to be assessed. So, जो पैटर्न है वो लग ये रहा है कि जैसा रॉयल कॉलेज का पैटर्न है तकरीबन हम उस तरफ लगता है कि जा रहे हैं. So in that perspective, if you look at the situation, what is being tested will be short cases. जैसे कि जनरल सर्जरी वगैरह में भी होते हैं, लेकिन जनरल सर्जरी में generally जब short cases होते हैं तो most of the time they are, I think, actual patients. For you, we were thinking that there could be role plays or there could be dummy in which you are supposed to demonstrate the examination. So we have kept a couple of scenarios in every class for you so that we can discuss them. And as we move forward, I think that we will also discuss examination. Now the thing is that there are various kinds of scenarios which can come to you. So basically it is TOEFL examination. So you're all familiar with TOEFL examination and you know that TOEFLs are of two kinds. They are interactive TOEFLs and static TOEFLs. So static TOEFL तो इसमें से निकल गए. अब रह गए interactive TOEFLs because each station is going to be, I think, 12-minute station will be there. So 12 minutes के अंदर खाली skill demonstration probability ये है कि खाली skill demonstration नहीं होगी. So even if it is a skill demonstration, you will be expected to justify why did you use that particular skill and the pros and cons, and there might be an examiner who might ask you questions related to that particular skill. So skills related to yoga. Skills going into routine हमारी list of skills हैं जिसके अंदर outlet forceps है, ventouse है, diagnostic laparoscopy है, use of various needle है, clinical examination is also skill, clinical examination है, MVA है, तो urodynamics की study skill उसमें नहीं आएगा urodynamics. So इस किस्म की चीजें basically जो skill में fall back करेंगी. Shoulder dystocia क्या है, management of PPH है, balloon tamponade है. These are all skills. So you might be given 2 or 3 options for a patient. So let's say there's a patient who's bleeding and she has got PPH. So you might be expected to identify that what is the assessment of blood loss, what are the next steps, and what are the methods of management of the patient that you're going to use to arrest them. So I think this is extremely important, and these kind of scenarios should also be kept in mind. So एक group हो गया जिसके अंदर स्किल के साथ उसके रिलेटेड क्वेश्चनिंग हो. दूसरा ग्रुप है जिसके अंदर there will be a scenario, and based on that scenario you will be asked question and answers, and you are going to reply according to the best of your knowledge. And in that, I think not only knowledge will be tested, but as if you consider almost the end of the first half of the Viva. So basically, uske andar you summarize the case, you talk about the relevant investigations and what are the probable management strategies that you can go for. सो इस तरीके से भी एक सिनेरियो बनाया जा सकता है जिसके अंदर सिनेरियो बेस्ड डिस्कशन हो जाए. सो अगर मैं आपको कहूं कि इट विल बी द सेकंड हाफ ऑफ द वाइवा by providing you the history of the patient. So history और examination की finding आपको बता दी और बाकी वाइवा बेस्ड डिस्कशन उसी तरीके से, क्योंकि अगर आप पिछले पैटर्न ऑफ एग्जामिनेशन को देखो तो उसके अंदर टोटल टाइम टू द कैंडिडेट यूज्ड टू बी 1 आवर. उस 1 आवर के अंदर there were 30 minutes which were there for history and examination and 30 minutes for the clinical case. उन 30 minutes के अंदर there were 8 minutes for the student to present the case, 11 minutes for one examiner and 11 minutes for the other examiner. So basically we have basically put together both the examiners into one और आपको उन्होंने history examination बता दिया, उसके बाद investigation of further management as a short case. Third scenario जो बनता है, मैम all these candidates are saying by please. Okay, मैं ऊंचा बोलने की कोशिश कर रहा हूँ.
Towards facing camera partners.
Okay. Guys, can you hear me now? Up clear है आवाज? Up clear. Okay. कैमरा किधर है? Okay. Okay, sorry बेट, मुझे पता ही नहीं था कैमरा इतना करीब होना चाहिए. Okay, so मैं एक दफा दोबारा कुछ चीजें रिपीट कर देती हूँ. The first thing I told you was that 12-minute station in which you are supposed to demonstrate a skill, and along with the skill you are going to be asked questions in which the examiner will be there. So एक आपका scenario ये बनता है. दूसरे टाइप के scenario आपके बनते हैं in which you will be provided history and examination findings by a clinical case based scenario, and you are going to be asked questions related to their related to the case, the investigations and the management plan for that particular patient. And I was saying that in the examination, in the long case that we used to conduct previously, उस long case के अंदर second half of the viva जो होता था 8 minutes होते थे case presentation के और 11 minutes each होते थे both examiner के. So basically if I look at it in scenario based questioning, those 11 and 11 minutes which are 22 have been converted into a 11 minutes one single station. So ये चीज भी हो सकती है. So ये दो different तरीके हैं जिनसे आपका बेसिकली जो है वो एग्जामिनेशन लिया जा सकता है. तीसरी चीज जो हो सकती है वो ये हो सकती है कि कोई कम्युनिकेशन का सेशन हो in which a dummy patient is presented over there and you are supposed to do counseling of that patient, and then that could be one station, because I personally think that communication is a very important part of the examination now, especially because you do not have a patient in front of you, so communication scenarios should be considered extremely important, and communication will be a very important part of your examination. The last thing which could be happening is that you are presented with a dummy in which you are supposed to perform a pelvic examination, and then the viva is conducted from there. So मेरे ज़हन में ये 3-4 सिनेरियो आते हैं जिन 3-4 सिनेरियो के ऊपर आपका जो है वो एग्जामिनेशन जो है वो चल सकता है. So I think we will start with the first scenario. Dr. Zara is here and she's going to present the first scenario, and we will be happy to take your questions in. Right?
Ma'am, these scenarios are basically on the counseling statement regarding the counseling of the patient.
तो मैं इसको जो मर्जी कन्वर्ट कर दूंगी तो मेरा तो सिनेरियो बताओ, बाकी मेरे पे छोड़ दो.
28-year-old patient, she had
ऊंचा बोलना पड़ेगा ताकि
a 28-year-old patient, she had miscarriage followed by full-term pregnancy, and she previously had an ectopic pregnancy for which she had self-injectomy 1 year ago. She is afraid to have another ectopic pregnancy. What are her chances of another ectopic pregnancy, and how will you counsel her that she can have a normal intrauterine pregnancy in future?
Okay. So can you summarize your case? I was confused listening to your scenario. Summarize.
I'm a 28-year-old female, and she previously she is a para 2+0. She had a normal pregnancy and
para 0 plus.
Sorry, yes, she is para. Sorry, ma'am. Para 1, abortions 1. She had a normal pregnancy followed by an ectopic pregnancy, which ended up in self-injectomy. And now, after 1 year, she came to you for counseling. That how?
I think you need to consider your history once again. First, you said she had a miscarriage. Then she said she had a full-term pregnancy. Then she said she had an ectopic. So, what is she? Because the first thing that you will be asked in the examination is to summarize your case. So you should be able to know how to give a good summary. So what is the summary of your patient?
28-year-old, para 1, abortions 2. She
Abortion to
with 2 miscarriages. Para
one
1
miscarriage. Yes, one miscarriage and one ectopic. So you just say para 1 plus 2, out of which the last child was the last pregnancy was an ectopic pregnancy. And so what at this time she's concerned. So my question is, what happened in that pregnancy?
In the last pregnancy, she had an ectopic pregnancy, and for which she had septicectomy. Her one tube was removed during the procedure, and now she is concerned that if she is able to get pregnant with a single tube, and what are her chances, likely chances of a normal intrauterine next pregnancy?
Okay, right. So anybody has any questions up till now? And can somebody time us? तो time please अपना timer शुरू कर दो मुझे 10 मिनट इसके लिए चाहिए. Okay, so this is a patient which you have who had a previous ectopic pregnancy and she's concerned. So if I am your patient, would you like to ask me any questions?
First of all, I would like to ask the patient regarding her previous her detailed history of the patient, her name, age, marital status, her residence where she lives, and then I will.
Does the residence where she lives make any difference to management in a short case? Do you think it's an important question for a short case? Not really, right? So you are going to frame your questions because you need to realize that you are in a 12-minute scenario in which you will take a minute to read the scenario. You will need about a minute to think about what you're going to do, and then you're going to ask the relevant questions to the patient. So you cannot go on asking all those questions that you used to ask when we were doing long cases. So what are you going to ask them? What more information do you need?
I would like to have the information regarding her past obstetrical history. Whether she had the miscarriage was followed by DNC and her normal full-term pregnancy was a normal was a spontaneous vaginal delivery or an elective cesarean section, and her self-injectomy whether it was an open laparotomy or it was laparoscopically done, and then I would ask her about her concerns regarding her current pregnancy.
Would you be asking her about the duration of her marriage?
Yes.
Why? Why would you want to know how long she has been married? Somebody is asking the risk of rule out risk factors for ectopic. Would you like to ask about risk factors for ectopic? What are the risk factors for ectopic?
Risk factors for ectopic are whether she previously had an ectopic pregnancy or not,
right?
Which is the most important risk factor, as there are chances that she might be having another ectopic pregnancy 7 by 10. There is 70% chance that she might be having an
70%.
7 out of 10. 7 out of 10 in 100. 7%.
Just 7%.
7%.
Not 70%.
No,
If it was 70%, what would you advise these patients?
Don't get pregnant.
Don't get pregnant. You are going to have an ectopic again. Please don't do this. So it is not
There is
70%.
70% chance that she can have a normal intrauterine pregnancy.
No, not 70%.
93%.
93% chance that she is going to have a normal pregnancy next time.
Yes.
Right?
Yes.
So my question is again, and the audience can also answer वो कर भी दें.
Yes.
What are the risk factors for ectopic pregnancy? What is the most I don't want to say most common, but in certain communities, it is a very common risk factor for ectopic. What is that? Infection. Infection is a very common risk factor for ectopic pregnancy. So you need to ask history actually of PID, right? Then somebody has written IUCD. I am not in for it that IUCD is a risk factor. वो उसका risk factor का तरीका बदल जाता है. Previous ectopic pregnancy, I do agree with you, and the risk of repeat ectopic pregnancy is not 17%. It is 7 to 10%. Endometriosis could be a risk factor for, and pelvic lesions actually are risk factors, and genetic factors are a risk factor. What are the type of previous surgery that was performed could also also be a risk factor. So this woman, after having a cesarean section, actually be at risk for ectopic
And whether
pregnancy.
there is another risk factor, whether the contralateral tube was normal or not when one tube was removed. The other status of findings.
COCP and progesterone use are not running. I don't think that they are risk factors for ectopic pregnancy, and I would be very unhappy to see this being stated as a risk factor. So contraception is हर contraceptive पर तो तुमने ectopic pregnancy का risk factor डाल दिया. That is not true. Uterine anomalies, I agree with you. Abnormally long fallopian tubes is also a risk factor for ectopic pregnancy. Right. So you don't know that it's risk factors for ectopic pregnancy. My next question is: this patient is extremely concerned about another ectopic pregnancy. What will you tell her?
I counsel the patient that there is a chance, a 7 to 10% chance of getting another ectopic pregnancy, but the likelihood of getting an intrauterine pregnancy is more as compared to the ectopic pregnancy. There is 90% chance that she can have a normal intrauterine pregnancy next time. And for that, she will be counseled that if she gets pregnant, she should get an early antenatal visit. She should start folic acid if she's planning a pregnancy at the moment. And she should also be counseled about an early ultrasound scan at 6 to 8 weeks to know whether she's having another ectopic.
You think 6 to 8 weeks is an appropriate time? Isn't it already too late? Because if it were ectopic, it would have ruptured by then. So out of the box for us, सोचो तुम्हें क्या ये सोचना चाहिए कि इसकी टॉपिक कब हुई? You really want to recommend another pregnancy very soon in a patient who's already para 1+2. So that's why I said that, are you interested in the duration of marriage? Are you interested in the age of the last child? So what is the kind of birth spacing that you would recommend to her? If she has recently had an ectopic pregnancy, the first thing that I would advise her is not to get pregnant for another 2 years, especially if she is young. So age of the patient, duration of marriage, and those medical histories. These are 3 important determinants before you advise her on a pregnancy and you start discussing ectopic pregnancy. So before discussing ectopic pregnancy, the thing that you need to discuss from the patient is that what are her plans, what does she do as well, what is her job, is she a working woman, is she interested in completing her family, ये वाली बात. उसके बाद आपने बात करनी है reviews of pre-pregnancy folic acid. उसके बाद आपने बात करनी है the importance of an early visit. And the importance of early visit means that as soon as the patient visits her period and confirms that she's pregnant, she should come back to you. And when she comes back to you, what are you going to do?
First, I will get her pregnancy confirmed. I will get her urine pregnancy test followed by beta HCG and early ultrasound done of the patient.
What do you mean?
First, we confirm the pregnancy.
I said that she has confirmed the pregnancy and she has come to you with a positive pregnancy test. What are you doing?
Ma'am, we will get her beta HCG level done.
Thank you. Why were you repeating scan again and again? Scan is not even reflective of what is happening. So you'll get a beta HCG done. So anybody who said a 6-week scan, Fatma, I don't agree with you. And with Naila, I don't agree with you. Early evaluation by ultrasound is too late at evaluation. So early evaluation first by beta HCG. And how are you going to do a beta HCG?
Ma'am, I will get her beta HCG done and I will repeat the beta HCG levels after 48 hours.
48 to 72 hours.
48 to 72
What should happen to the beta HCG 48 to 72
Ma'am, they
hours?
should double.
Minimum. Yeah.
Yes, ma'am.
So they should double.
Yes.
And if they are doubling, then you can tell the patient that she can be sure that it is not an ectopic pregnancy. And then at 5 weeks, what is the earliest time that you can see a gestational sac?
At 5.
At 5 weeks. So at 5 weeks, you do a transvaginal ultrasound to look for a gestational sac, not at 6 weeks, because 6 weeks you can even see the heartbeat. It's very good, right? So if the doubling time is not enough, then you will keep the patient under observation. If she's not the beta, if the beta HCG is not doubling in 48 hours, what is the differential diagnosis?
Ma'am, it
That's
can be a
it,
missed.
that's it, okay?
Ma'am, it can be an ectopic pregnancy, it can be a missed miscarriage, it can be a pregnancy of unknown location, or ma'am, cervical ectopic, or
It could be a pregnancy which is actually a chemical pregnancy.
Yes,
and the beta HCG levels might be
Yes.
dwindling down, right?
yes,
So if the beta HCG is not doubling, it is not a confirmation that this is a pregnancy of unknown origin or this is an ectopic pregnancy. It just means that you need to keep the patient on your radar and repeat the beta HCG again and then accompany it with a transvaginal ultrasound to look for unknown sites where pregnancy could happen,
yes.
right? So what else do you think are the concerns of the patient?
The concerns of the patient are that whether she can get a normal pregnancy next time her pregnancy will be a intrauterine pregnancy or not, and if she gets another ectopic pregnancy, what will be her mode of management in that case?
Okay, so if as a doctor you diagnose that this time it's again an ectopic pregnancy,
Yes.
what are you going to do?
Ma'am, it will depend. It will depend on the beta HCG levels of the patient. We can give her expected management or medical management or surgical management, but it depends on at the time of the patient presentation of the patient. If the gestational sac does not have a fetal cardiac activity, there are no signs of rupture, intrauterine rupture. The beta HCG levels are between 1,000 and less than 1,500. We can tell the patient that she can have methotrexate and medical combination. And if there are signs of any rupture, then we will go towards the surgical.
What about expected management? You said
Yes, ma'am, less than
Uh-huh.
1,000. Yes.
Well,
Yes, sir. Ma'am, expected management if the beta HCG levels are decreasing after 48 hours and there are no signs of rupture and there is just early ectopic pregnancy, then we can give the patient expected management just by monitoring her beta HCG levels.
So for expected management, would you admit the patient in the hospital? What are you going to do?
No, we don't need to admit the patient at the hospital. We can counsel the patient. We can tell the patient in detail that the signs of the rupture of ectopic pregnancy, and we can tell the patient if she gets any lower abdominal pain, she can go home and she will be repeating her beta HCG levels. We will be repeating her beta HCG levels. But if the patient has
So
any
how
signs,
frequently do you remove? Do you repeat the beta HCG level in a patient with whom you are doing an expected management?
At 48 hours, after
48
48
hours,
hours, yes,
okay,
ma'am,
okay.
if they are decreasing, then we move towards weekly levels and
No, but initially
yes,
you are
ma'am,
going to
initially,
do it
yes.
after 48
yes,
hours
until they get
to
home.
see what is happening with the patient.
Yes.
So what is the advantage? How do you do medical management of an ectopic pregnancy?
We give the patient injections
Is
and
there
there
any
is single dose. Yes, so there is criteria of the medical management. Ma'am, if the beta HCG levels are
बेटा खत्म हो गया एक सवाल क्या आखिरी सवाल चल
ma'am, if the beta HCG levels are less than 1,500, there are no signs of a ruptured ectopic pregnancy. The gestational sac size is less than 3 centimeter, and there is no fetal cardiac activity present in the gestational sac. Then we can go towards the medical management.
less than 1500 पर you can expect that
Not less than 5,000.
Five-
Less than
1,500 to
5,000.
5,000.
5,000 yes 1500 to 5,000 if the value is less than 5,000 the gestation sac is less than 3
3 centimeter, and there is no fetal cardiac
and there is no fetal cardiac activity then you can go for medical management.
and no signs.
How do you do medical management?
Ma'am, we give methotrexate 50 milligram per kg body weight of the patient. There is single dose and double dose. 15
1 milligram
1
per
milligram
kg.
per kg. Yes, ma'am, and 50 milligram.
So 50 जरूरी नहीं है हो सकता है
1
अगर
milligram
80
per
pound
kg.
dose पे
Yes,
तुम आपको
ma'am.
80 kg हो तो तुम वो तो 50
Yes.
दे सकते हो. For effective management it has to be 1 milligram
1
per
milligram.
kg body weight. What else?
And then, madam, we
Baseline investigations तो कराएंगे ना कि seriously hemoglobin
जी हम LFT
Etc.
counseling.
So give me some देखो okay. So there's a very interesting comment that she said. She said कि मैं काउंसलिंग याद करके आई थी तो मुझे इस सवाल के
नहीं
पहली बात नहीं है. This is also counseling. Whether it is a counseling session, whether you are telling the patient or you are telling the consultant, it's the same treatment. So तुमने तो तैयारी पूरी करनी है ना. And a couple of very important points have been raised by the audience, and they want to know 50 milligram kg no Naila, this is not right. 1 milligram per kg body weight, methotrexate की dose है. Patient should be willing for follow-up. Actually, patient should be explained that how important follow-up is. Folinic acid is not required with the first dose of methotrexate. Only if you are given methotrexate repeatedly, only then folinic acid is required. Or counseling of the patient is extremely important in this. एक मैं बात बताऊं. So I just want to give you a little bit of feedback. Now you are a candidate जिसने ना सारा वाइवा एक ही टॉप में. So उसमें कुछ क्वेश्चन ऐसे हैं या तुम एज ए डॉक्टर कुछ चीजें पेशेंट पे एम्फसाइज करोगी, कुछ चीजें ऐसी हैं जिनको एम्फसाइज करने की जरूरत है. So your tone of answering should be such that in patients whom you think that these things are important, तुम्हारी बात का तरीका उसको इजहार करे उसका. So for example, when I said how you going to medically manage this patient, तो मैं पहला कहना चाहिए कि इस patient के साथ counseling very important है. This patient की understanding very important है that even when she is under, for example, even if she is under expectant treatment, she can actually have a raised level of intensity. There's still possibility, although the possibility of rupture is very low. That is why you kept the patient for expectant management. Otherwise, expectant management में ना रखते. So there are certain instructions that you need to give, considering that in Pakistan patients do not come back for follow-up. So it is important to make sure that the patients have to be told that they should come back for follow-up. In medical management, there are two ways of going around it. Some people would say you admit the patient. Like in government hospitals, people normally admit the patient. In private facilities, most of the time you do not admit the patient. So if the patient is hemodynamically stable, it is not necessary to admit the patient, provided she understands that if she has the slightest sign of rupture of ectopic, she will present to the hospital immediately. And the rupture of signs, the signs of rupture of ectopic pregnancy are acute pain, fainting attack, epigastric pain, blah blah blah. So you have to tell the patient. You also have to tell the patient that she cannot have intercourse while we are giving her either medical or expectant treatment because there is a possibility of rupture. So all these things understood, only then you can go for either medical or expectant management, right? ये बात बतानी बड़ी जरूरी है. And you also have to tell the patient that once you have confirmed that it is an intrauterine pregnancy, then your problem is over. Then you are going to manage the patient as you would manage any other ectopic pregnancy. Okay, so counsel regarding the drug side effects, I agree. Monitor the LFTs. So I really do not think that LFTs, RFTs, and CBC have to be monitored as such. But if you are repeating, पहले आपने baseline करवा दिया, आपको बार-बार करवाने की जरूरत नहीं है. But if you are repeating your dose of methotrexate, then I would agree with you. Give alternate options. Then if medical treatment fails, surgical treatment, yes. And preferably, ectopic pregnancy should be managed by laparoscopic surgery. If it is need for surgery, it should be laparoscopic surgery. For Linux acid Adila, हमने पहले discuss किया, one dose of methotrexate does not need folinic acid, but if you are repeating methotrexate, then the answer is yes. Any other questions? 1 milligram per kg body weight, Shelly? Yes. This is not the dose of folinic acid, this is the dose of methotrexate. Right. आप लोगों के कोई question? No question. ऐसी कोई चीज जो कि इसमें बताई जाए कि तुम लोग समझते हो तुम देखकर बता सकते हो. Okay. Let's think about ectopic pregnancy. Let's say that the ectopic pregnancy ruptures. So now you have a patient in which there is ruptured ectopic pregnancy, and she has presented to you.
Then, ma'am, if the patient is presented with a ruptured ectopic, we will do her emergency management. We will get her emergency ultrasound done. We will get her all baseline investigations done. We will arrange the blood, and we will immediately we will see if the patient is hemodynamically stable or not, and we will immediately shift the patient for emergency laparoscopic self-injective or self-injective.
Laparoscopic surgery.
So laparoscopic.
What will you do at the time of laparoscopic surgery? Resuscitate the patient only if the patient needs resuscitation. Okay.
Ma'am, at the time of laparoscopic surgery, we will see if the tube has ruptured.
सारा आप लोगों को confuse कर रहे हो. Please इसको 1 milligram per kg body weight रहने दो.
Body mass is not.
वो ठीक है. लेकिन मैं इसलिए ये बात कह रही हूँ क्योंकि आप लोग normally अपने clinical situation में क्या करते हो? आप body M2 निकालते हो. तो जब आप निकालते हैं
CA वाले जो होते हैं ना oncologist वो निकालते हैं surface area.
सर oncologist निकालते हैं, आप निकालते हो, आप नहीं निकालते हैं, so don't say it please. ठीक है? Even if she is hemodynamically stable and the tube has ruptured, she needs surgery. It is not that if she is unstable only then surgery is required. So जो laparoscopic surgeon है, they can do laparoscopic surgery even on a patient who is not hemodynamically stable. So it depends on the expertise of the person. It is not necessary that if the patient is not stable, तो आप उसकी laparotomy करें. मैं आपसे नहीं करती. Salpingectomy or salpingotomy? That is the question. So salpingotomy can be taken.
be evacuating the, we won't be taking out the tube, and we will just taking out the gestational sac, and we will do hydrodissection. We can do hydrodissection for that as well, and we will leave the tube as it is, so the patient can have next time pregnancy. But if
so that the patient can have another ectopic pregnancy. That is the only objective of हम लोग छोड़ते हैं, हम सारे छोड़ते हैं एक year as a pressure of leaving the second tube, but remember that there was something wrong with the tube, that is why ectopic happened. So even if we leave the tube, there is a greater actually probability that you will have an ectopic. So आपने patient की दोनों ट्यूबें निकाल दी, patient आपके पास रोटी आ गई है, क्या आपने मेरी दोनों ट्यूबें निकाल दी, क्या एडवाइस?
But I still have a chance of IVF, and she can take a chance of IVF pregnancy, as her both tubes have been moved, and she can go for PCOS.
Okay, let's have the next scenario. किसका scenario है?
Online candidate.
Online candidate, do you have a scenario?
Yes, doctor, I have it.
Okay, great. Can we hear it?
Yes, doctor. Doctor, can you hear me?
Yes,
Yeah.
we can hear you.
Yeah. 42 years old, known hypertensive, married since 22 years, para 3 plus 0. Normal vaginal delivery followed by previous one cesarean section. Last born 9 years back. Has presented with irregular heavy menstrual bleeding from last 1 year. Currently, the patient is on tablet norethistron. On per abdomen examination, abdomen is soft, non-tender, no mass palpable. On bimanual examination, vulva vagina is normal, estrogenized. Uterus is 12 to 14 week size, mobile, non-tender, and fornices are clear.
Abdominal examination की finding क्या बताएंगे? Please repeat.
Abdomen is soft, non-tender, and no mass palpable.
Okay. So यहाँ तुम पकड़ी जाओगी जब तुम ये बात कहोगी, और फिर तुमने pelvic examination पे क्या कहा? 14 weeks. Uterus is 14 week size. 14 week size uterus should be abdominally palpable.
Yes, doctor, but I was not able to palpate it on abdominally. It was just bimanual examination was.
If you have not been able to palpate or percuss a uterus on abdominal examination, then it cannot be 14 week size. So आप उसका जवाब जो है वो अपना modify करें, वो 14 week size uterus नहीं हो सकता. अगर आपने उसको PA किया, PA पे palpate नहीं हुआ uterus, and आपने pelvic पे उसको feel किया, तो maximum size that it can be is 12. So I will not call it a 14 week size uterus. Okay. My second question to you is, you said well estrogenized epithelium. What do you mean by that?
That means the hair growth was appropriate.
What was appropriate?
The hair growth was normal.
Which
The
hair
hair
growth?
growth was normal looking.
कहाँ की
The hair growth on the vestibule, on the vagina was.
Vagina में तो hair follicle ही नहीं होते.
Sorry, doctor. Vulva. On inspection, there were the hair distribution was normal.
आप कहाँ से हो?
I'm from Karachi.
कराची. आपको ये पता होना चाहिए well estrogenized epithelium जो होती है या well estrogenized जो होता है, that is not reflected by the hair distribution. Number one. Well estrogenized आप उसको कहते हैं जब आप vagina को देख रहे होते हैं, and that is not because of the presence of hair, it is the presence of lubrication, which shows you that it is a well estrogenized epithelium. The second thing is, why are we thinking about estrogenization of epithelium in a woman who's 42? 42 में estrogen का ताल्लुक क्या है? Why are we talking about it? Can you explain?
Doctor, at this stage we should not talk because the patient is not in a menopausal stage. She's in a
No, but
perimenopause phase.
my question is, why did you mention that? Because I want to understand from the perspective to जो आप यहाँ बोलते हो इतने सारे लोग सुन रहे हैं, so वो सारे के सारे है ना, उसको follow कर सकते हैं. 42 में ऐसा perimenopause नहीं होता, perimenopause में estrogenized आ रहा है epithelium. फिर तो menopausal होगी तो उसका estrogenized effect होगा vagina के ऊपर बना नहीं.
Doctor, फिर हम यही बोलते हैं vulva vagina is normal looking because we have to comment on the inspection of the patient. That's why I said so.
Normal looking कह दें, लेकिन short case के अंदर जो है ये significant नहीं है, but हाँ, I agree with you. You can say it is normal looking. Now let's look at the case once again. So 42-year-old hypertensive, para 3 plus 0. Whether she had a previous cesarean section or not, I don't know whether it is significant to your history. पता चल जाएगा.
Normal vaginal delivery followed by two normal vaginal delivery followed by previous one.
तो क्या ये हमारी मैनेजमेंट पे इफेक्ट करेगा?
No, doctor.
तो फिर इसका मेंशन करना कोई इतना जरूरी नहीं था. मैं प्रेजेंटिंग कंप्लेंट के बारे में बात करना चाहती हूँ. What is your presenting complaint?
irregular heavy menstrual bleeding from 1 year is my
ये
presenting complaint.
presenting complaint गलत है. इसको कैसे express करोगे?
Doctor, because the patient was menstruating twice or thrice
जब
a
आप
month.
मेरी जान सुनो, जब आप heavy menstrual bleeding कहते हो ना, तो वो HMB होती है.
जी,
जो वो क्या होती है HMB? HMB में periods हमेशा regular होते हैं. तुम जो बात कहना चाह रहे हो वो ये है that the patient has irregular vaginal bleeding.
जी.
Am I making sense to you?
Yes,
The
doctor.
patient has got irregular vaginal bleeding. दोनों इकट्ठे नहीं हो सकते.
सही. मैडम
ठीक है?
बस मुझे ये बात क्लियर करनी थी, जैसे एक पेशेंट जो है if she is bleeding thrice a month for 7 days, then she has just 4 bleed free interval, then again she starts bleeding, then won't we say that an irregular heavy menstrual bleeding?
You just say that she has got irregular heavy vaginal bleeding, and basically what you are saying is that there is no pattern of bleeding. If there is no pattern of bleeding, it is called metrorrhagia. मैं तुम्हारी सिर्फ understanding के लिए बता रही हूँ, right?
Okay.
Heavy menstrual bleeding is always regular, I agree, and the causes of heavy menstrual bleeding and irregular vaginal bleeding also differ. So जब आप कहते हो heavy menstrual bleeding, तो differential diagnosis क्या आती है? माइक में बताओ मुझे. Heavy menstrual bleeding का DD
Heavy
क्या है?
menstrual, madam, the first differential diagnosis is fibroid uterus. Second
good.
could be adenomas. Second could be polyp, endometrial polyp, or the third could be adenomyosis, and the
True.
fourth could be endometrial hyperplasia.
Okay, so we are good. ये आपने बता दी heavy menstrual bleeding की differential diagnosis. Now your patient has got irregular vaginal bleeding. इसकी differential diagnosis बताओ.
In irregular, the first thing would be endometrial hyperplasia, PID.
मैं तो first thing ये नहीं सोचूंगी अगर irregular vaginal bleeding है. Would you not think of endometrial carcinoma? You will not think of endometrial polyp.
Yes.
Polyp नहीं करेगा irregular vaginal bleeding. Endometrial
जी.
cancer irregular bleeding करेगा. Cervical cancer irregular bleeding करेगा. Irregular use of hormones irregular bleeding करेगा. IUCD
PL.
irregular bleeding करेगा.
Yes.
मानते हो?
जी, contraceptive.
Pregnancy, I agree with you. ठीक है ना? So irregular in Pakistan, the most common cause of irregular vaginal bleeding is the erratic use of hormones. Normal size uterus है, दवाइयाँ खाई जा रहे हैं. जब bleeding बंद होती है, primary time बंद हो जाती है. जब bleeding शुरू होती है, primary time खाना शुरू कर देते हैं. This is the most common cause of irregular vaginal bleeding in our country. Now you tell me you have a patient who has got irregular vaginal bleeding and a 12-week size uterus. अब differential diagnosis क्या है?
Irregular with 12 weeks. Mine first would be fibroid. Could be endometrial polyp.
Okay.
Endometrial polyp. Then, as you said, endometrial cancer, cervical cancer, and the usage of progesterone and IUCDs.
So my question is that is there anything in the examination that we have missed?
Madam, like it was uterus was 10 to 12 week size, mobile, non-tender, and fornices were clear.
इन्होंने
And
बताया
bleeding.
था well estrogenized everything है,
Yes, doctor, well estrogenized.
है ना? So my question to you is कि well estrogenized तो आपको PS करती नजर आई होगी ना? So what did you miss?
I missed the speculum examination over here.
What do you want to see on
The
speculum?
cervix, because in the speculum examination, we'll see the position of the cervix, how the cervix is, whether it is central, is there any signs of hyperemia,
Central
or
cervix, my dear, central cervix is not important. The important thing is the look of the cervix. And the other thing that you want to look for is a polyp.
any polyp.
Polyp
Yeah.
की presenting complaint क्या होती है? चलो मुझे इसको different तरीके से frame करने दो.
इसके अंदर irregular intermenstrual bleeding होगी, postcoital bleeding, and irregular menstrual bleedings. There are
Oh.
three presenting complaints.
It is mixed with vaginal discharge. Foul
Yes.
smelling भी होती है. जो polyp है उसमें there could be a foul smelling bleeding. And if it is a cervical cancer, then
सर्वाइकल कैंसर में बहुत एक्सेसिव डिस्चार्ज प्लस ब्लीडिंग और बहुत ज्यादा फाउल स्मेलिंग होता है सर्वाइकल कैंसर में एज कंपेयर टू पॉलिप.
exactly. So if there's a growth, all these things will be there. So now my question is that what investigations do you want to carry out in your patient?
There are certain baseline and specific investigation. I'll start with the
एक
complete.
मिनट मैं आपको थोड़ा सा रोक रही हूँ. एक मैं पॉइंट ऑडियंस के लिए रेज करना चाहती हूँ. अब ये क्वेश्चन हमने ये चीज डिस्कस की है कि स्पेक्युलम एग्जामिनेशन वाज नॉट मेंशन्ड और स्पेक्युलम एग्जामिनेशन में जो चीजें देखनी चाहिए इफ यू हैव प्रेजेंटेड अ केस इट इज नॉट बीन मेंशन्ड. सो ऑल्दो वाइवा का आगे चला गया है लेकिन आपका एक नेगेटिव स्कोर हो गया है फॉर द स्पेक्युलम एग्जामिनेशन व्हिच यू मिस्ड इन दिस पर्टिकुलर केस क्योंकि इरेगुलर वैजाइनल ब्लीडिंग के केस में स्पेक्युलम एग्जामिनेशन इज ऑफ extreme importance. You understand what I'm saying?
Yes, doctor.
So sometimes वाइवा चलता जाता है और आप जो है वो एंड तक पहुंच जाते हो और फिर फेल हो जाते हो. तो आप वरी करते हो या वंडर करते हो कि मैं इसमें क्यों नहीं पास हुआ. आप इसमें इसलिए नहीं पास हुए अगर आप डिफरेंशियल डायग्नोसिस नहीं बना सकते, अगर आप उसका स्पेक्युलम एग्जामिनेशन की बात नहीं करते तो फिर आप you are heading towards an unsatisfactory mark for yourself. Okay, अब आप मुझे बताएं.
Madam, I'll start with my baseline, starting with complete blood count, hemoglobin, total leukocyte count, and the platelet count. But as you want the relevant exam for the specific investigations, I need the serum TSH and any endometrial sampling or any pipal report has been done, and ultrasound, transvaginal ultrasound to see the echogenicity of the uterus, the size of the uterus, endometrial thickness, endomyometrial junctions, and any adnexal pathology and the ovarian morphology.
Okay, so
And
your
pap smear.
and pap smear.
And pap smear as well.
Pap smear पहले हो जाना चाहिए था, तुमने भी यहाँ से पढ़ के बताया. Okay, so my question to you is that on ultrasound there is myo texture is disturbed and her hemoglobin is 7.
So now I have to tell you the diagnosis for this patient.
Yes.
So my first differential, my provisional diagnosis is adenomyosis because the myometrial texture has been disturbed.
Okay.
So,
Then how do you explain the irregular vaginal bleeding?
but madam, in adenomyosis is always a regular heavy menstrual, regular bleeding, regular heavy menstrual bleeding. There won't be any irregular in that.
So फिर irregular क्यों है?
Maybe due as the patient is in perimenopausal age group, plus maybe there's any coexistence pathology along with it, because there's 30% chance of any coexistence
Or
as well.
maybe the patient is on progesterone.
Yes.
So what will you do if the patient is on progesterone and she has got adenomyosis and the hemoglobin is 7? क्या करोगे?
The first step is optimization of hemoglobin. I'll build up her hemoglobin. The secondly,
कैसे
I will.
build up होगी? The patient continues to bleed. How can you optimize the?
I can optimize by giving her parenteral irons and keep the patient.
If Professor Rashid is ready, तो मैं जो हूँ मैं इसको खत्म कर देती हूँ. Just one more minute. I think that one thing is very important over here, and that important thing is I agree with Rania that we need to talk about the role of hysteroscopy. The second thing is that if the patient is on irregular use of hormones, the hormones have to be stopped. They have to be stopped. The hemoglobin has to be built up, and then the management plan could be either a marina or a definitive treatment. I think that if we are able to build up a hemoglobin, the bleeding is controlled, then marina is the treatment of choice. I think we will stop over here and hand over to Professor Rashid.
Thank you, madam.
Thank you very much. I think it was a good
Jazakallah, ma'am.
Thank you so much.
Thank you, ma'am. Very nice class. Very nice.
Thank you, dear ma'am.
Thank you very much. I love you guys.
Thank you, ma'am. I love you, ma'am.
I meet you, yeah. Next week, next Wednesday, we'll start at 8:30.
Candidates.
Yes, ma'am. We will
If
wait
you
for you.
guys have your own scenario, you can bring your scenario and we can take one or two scenario candidates.
Thank you, ma'am.
Lucas and Marina, I don't think that's a good choice. It won't work. Sarah?
Okay, madam.
Sir को connect कर. Sir को सुनाओ. नीचे जाके.
अभी तो नहीं है.
इन लोगों ने मैसेज किया था. If sir is not here, वैसे sir नजर तो आता. ये मीटर
सही है।
मैडम अस्सलाम वालेकुम। हेलो मैडम अस्सलाम वालेकुम।
वालेकुम सलाम।
मैम एक्चुअली आप जो पहले एग्जाम पैटर्न बता रही थी उस वक्त आपकी आवाज क्लियर नहीं आ रही थी टोटल 12 मिनट्स के बारे में, तो आप प्लीज रिपीट कर सकती हैं?
सो मैं इसको ऐसा कर रही हूँ, अभी प्रोफेसर राशिद इज ऑलरेडी हियर, तो मैं नेक्स्ट वेडनेसडे पे जब क्लास होगी आई विल रिपीट दिस होल थिंग अगेन। ओके, मुझे एक मिनट चेक करने दें कि सर
ओके
लाइन
मैम,
पे है।
थैंक यू।
2 मिनट तक आएंगे
सर 2 मिनट तक आएंगे, तो मैं थोड़ा सा बता देती हूँ। मैंने आपको ये कहा था कि इसके अंदर आपका जो पैटर्न है वो 2 इंपॉर्टेंट तरीके हो सकते हैं। एक तरीका ये हो सकता है कि वही टोक्स जो कि आप लेने के यूज टू है, उन्हीं टोक्स को थोड़ा प्रोलॉन्ग करके कर रहे हैं। तो व्हाट आर दे गोइंग टू आस्क यू इज टू डू अ स्किल decision making over there and then discuss the case with the examiner। जैसे कि मैंने एक एग्जांपल के तौर पे कहा था कि अगर एक पीपीएच की पेशेंट है तो उसके अंदर एस्टिमेटेड ब्लड लॉस का एक आपका हो सकता है कि आप ब्लड लॉस एस्टिमेट करें, then you diagnose PPH and then you manage PPH and discuss with the examiner what did you use to manage PPH and why। So एक तो आपका ये हो सकता है कि स्किल बेस्ड सिनेरियो के साथ डिस्कशन डाल दें। एक तो 12 मिनट का आपका टॉक स्टेशन ये हो सकता है। एंड यू नो ऑल द स्किल्स दैट वी हैव बीन डूइंग, व्हाट यू नीड टू develop is ability to justify what you did and why। The second type of stations are, as I said, कि उसके अंदर interactive station होगा with a case based scenario। जैसे मैंने कहा था कि जो second half of वाइवा होता है उसमें 8 minutes are given to present the history, 11 minutes each are given to the candidate with each examiner। So वो जो 22 मिनट है उसको आपने 11 मिनट में जो है वो स्क्वीज कर रहे हैं। So you have to talk of things which are relevant, which are salient to your case and not talk of things जैसे कि पहले हम अभी मैंने किसी को कहा था कि जी आपको इसके अंदर वो बातें पूछनी है जो कि आपके केस से रेलेवेंट है, बाकी बातें पूछने की जरूरत नहीं है। ठीक है, सो ये मैंने बताया था। तीसरी बात मैंने कही थी कि इस एग्जाम के अंदर मेरी नजर में कम्युनिकेशन एंड काउंसलिंग बहुत इंपॉर्टेंट हो जाती है, तो आपको काउंसलिंग के लिए पूरी तौर पे तैयार होना चाहिए। चौथी बात मैंने ये बताई थी कि जो ये आपका टेस्ट करने की कोशिश करेंगे वो एप्लीकेशन ऑफ नॉलेज है, इंटरप्रिटेशन ऑफ नॉलेज है, स्किल है, जस्टिफिकेशन ऑफ स्किल है। Yes, I agree, Rania. It is almost like the part 3 of MRCOG. So उसके पैटर्न के मुताबिक लग रहा है कि ये जो है ये चलेगा, जिसके अंदर आपको डमी भी हो सकती है फॉर परफॉर्मिंग अ pelvic examination because there is no other way। जिसके अंदर लाइव पेशेंट नहीं होगा। So या तो आपके पास पेशेंट होगा जो काउंसलिंग वाले पेशेंट बैठे होंगे वो होंगे, या फिर आपके पास डमी होगी to demonstrate pelvic examination and other skills। Do I answer your question? Okay. Thank you, Ramya। और कोई क्वेश्चन तुम लोग भी पूछ सकते हो, वांट टू आस्क एनीथिंग। लेकिन मैंने एक बात कहनी है, I personally think that this will take a lot of your energy। So आप में से वो लोग जो कि ओपीडी को या केसेस को ये समझ रहे हैं कि ये इसके होने से जो है, मैं एमआरसीओजी की बुक्स बताऊंगी जो पढ़नी चाहिए सारी ना पढ़ना। सर अस्सलाम वालेकुम।
1 मिनट सर की ऑडियो कनेक्ट हो
सर
रही है।
देख सकते हैं,
ऑडियो कनेक्ट हो रही है सर की अभी। ओके
सर अस्सलाम वालेकुम।
सर का माइक म्यूट है।
आपका माइक म्यूट पे है सर, अनम्यूट कर लें।
इमरान साहब सर का माइक अनम्यूट कर दें।
सर अभी भी म्यूट पे है।
जी
अब
ठीक है
आगे
सर।
जी सर आ गई है। अस्सलाम वालेकुम।
माशाल्लाह यू लुक गुड।
थैंक यू।
क्या पढ़ाया है?
सर हमने 2 केसेस डिस्कस किए हैं। वन वाज ऑन इरेगुलर वैजाइनल ब्लीडिंग इन अ 42-year-old और दूसरा हमने डिस्कस किया a patient who had a previous ectopic pregnancy and she's concerned that she might have another ectopic next time। So उसकी काउंसलिंग डिस्कस।
तुम तो बड़े ओके ओके सब्जेक्ट डिस्कस करती हो, मुझे तो सिंपल एंटीनेटल केयर नहीं आती।
सर ये आपकी मोहब्बत है, हमने तो आप ही से सीखा है। Everything that I know is directly from you।
ना 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 माशाल्लाह ये सारा तुम्हारा अपना है, ऑल योर्स। देखो क्लास में 100 लड़के बैठे होते हैं, लड़कियां भी होती हैं कुछ, अब तो कुछ लड़के होते हैं।
हाँ बिल्कुल चेंज हो गया।
all of them don't imbibe with same intensity, same quality, and different levels altogether. You were different. That's why you are there. रुबीना, मैं तो आज इनको जो नया टोक सिस्टम आया है,
जी सर,
मैं बार बार हर क्लास में ये दोहराऊंगा, वो किसने बनाया, क्यों बनाया, कैसे बनाया, वो तो जेर बहस नहीं है, वो तो बन गया है, तो उसको तो डिस्कस भी नहीं करना चाहिए. तो whether I am for it or against it doesn't matter, लेकिन it's there, the system is there. ये बच्चियां जितनी बैठी हैं, they have to face that music. तो मैंने वर्कआउट किया है कि वो पुराने टॉक्स में 5-6 स्टेशन नए ऐड करेंगे. This is what Tayyib told me. और वो तकरीबन 14-15 या 20 मिनट का एक स्टेशन होगा. अब हाँ जी, अब मैंने पर्चा इस तरह से आउट कर दिया है, मैं स्टेशंस के नाम ले देता हूँ. तुम लकीली फॉर मी यू आर सिटिंग देयर, तुम उसको इम्प्रूव करना. एक स्टेशन तो होगा स्टैंडर्ड, जैसे लॉन्ग केस होता था ऑब्स्टेट्रिक्स का, एक स्टैंडर्ड लॉन्ग केस गायनेकोलॉजी का होगा. जैसे लॉन्ग केसेस होते थे वो उसकी समरी बना के वो प्रेजेंट कर देंगे, फिर जैसे लॉन्ग में होता था वही यहाँ पे भी होगा. 2 स्टेशन तो ये निकल गए. अब आपकी मेरी जिम्मेदारी या रिस्पॉन्सिबिलिटी ये बन गई, नंबर 3 स्टेशन जो है वो इनमें से हाथ खड़ा करवा लेना कि इनको कभी किस ट्रेनिंग के दौरान किसी ने इस टॉपिक पे बात की है या नहीं की. वो है काउंसलिंग. एक स्टेशन आएगा कि ये हादसा वाकया हो गया है या पेशेंट इस प्रॉब्लम के साथ हमारे पास आई है, हाउ विल यू काउंसल. सिंपल काउंसलिंग. वो जो 4-5 मेजर प्रॉब्लम है, लेकिन रुबीना आपको और मुझे इनको सिर्फ काउंसलिंग के स्टेप्स बताने हैं. वो इन्होंने हर एक, चाहे कोई भी प्रॉब्लम है, चाहे अनीमिया की है, चाहे हार्ट फेलियर की है, चाहे जैसा आपने कहा एबनॉर्मल यूट्राइन ब्लीडिंग की है, कुछ भी है, वो 5-6 स्टेप्स जो हैं स्टैंडर्ड, जो मैंने कहा ना, इन्होंने प्रैक्टिस भी नहीं किए कि आप अपने आप को इंट्रोड्यूस करोगे, फिर बताओगे प्रॉब्लम क्या है, फिर उसके बताओगे प्रॉब्लम की उसकी या उसके बच्चे पे क्या असर हो सकता है, फिर हाउ विल यू इन्वेस्टिगेट एंड देन मेक ए फाइनल डायग्नोसिस, उसके प्रोज एंड कॉन्स क्या होंगे. ये 5-6 स्टेप्स हैं जो हर एक ये दोहराएंगे तो पास हो जाएंगे. जो कि nobody is being counseled or being taught on these lines. वो strict, तुम्हारी किताब में लिखा हुआ स्ट्रिक्ट प्रोटोकॉल है. मैं रात तुम्हारी किताब देख रहा था, उसमें से बहुत सारा मैंने उठा लिया मटीरियल, तो थैंक यू फॉर दैट. वर्बली कॉम्प्लीमेंट कर रहा हूँ, उसमें नहीं किया, किताब में नहीं किया. तो और
अगली में लिख दीजिएगा.
चलो, तो वी हैव टू टीच देम कि ये 5-6 स्टेप्स हैं कि वो टोटल काउंसलिंग के नीचे मोटा सारा लिखो, एम्पैथी. You have to show empathy throughout. वैसे एम्पैथी हमें आती ही नहीं एक्सप्रेस करनी. मैं रात अपनी बीवी को बता रहा था कि हमारे एक क्लास फेलो दोस्त का बाप मर गया. 4-5 दोस्त मिले कि चल के उसके बाप का अफसोस करके आए. जाके बैठ गए. अब अफसोस करने का भी हमें अंदाज नहीं आता, वही काउंसलिंग आती ही नहीं. 5-7 मिनटों के बाद उनमें से एक लड़का बोलता है, अच्छा फिर वालिद साहब ठीक ठाक फौत हो गए। अब ये है हमारी काउंसलिंग।
सर हमारी काउंसलिंग ये है, अफसोस करने आते हैं, हालात हादसा की बात करके घर चले जाते हैं और पता चलता है अफसोस करने आए थे। बाद में उनके जाने के बाद पता चलता है कि ये तो अफसोस कर रहे थे। तो वाकई दैट आल्सो नीड्स टू बी टॉट।
तो एक काउंसलिंग का वो स्टेप्स जो है ना 5-6 इनके ज़हन में बैठ जाए, चाहे प्रॉब्लम कोई भी हो, कि दे हैव टू शो देयर एम्पैथी थ्रू आउट। पहले अपना नाम बताएं, फिर उसको जो भी है बताएं कि तुम्हारी ये प्रॉब्लम है, उसके क्या कॉन्सिक्वेंसेस हैं, उसकी अपनी हेल्थ पे, बच्चे की हेल्थ पे, फ्यूचर पे, और कहें पॉसिबल ये डायग्नोस है। मैं अभी तो फिर कुछ इन्वेस्टिगेशन करूंगी, कंफर्म करूंगी। फिर जब कंफर्म, डोंट हैव टू नेम ऑल द इन्वेस्टिगेशन, लेकिन जब डायग्नोसिस कंफर्म हो जाएगा फिर मैं उसको बताऊंगी ये तो हो गया पक्का। अब इसको मैनेजमेंट मेडिकल है, सर्जिकल है, क्या है क्या नहीं, और फ्यूचर की उसकी जिंदगी पे क्या असर होगा, फ्यूचर प्रेगनेंसीज पे, फ्यूचर लाइफ पे। ये 6 स्टेप्स हर कोई दोहरा दे तो पास है, उस स्टेशन पे पास। चाहे एग्जामिनर का एग्रीमेंट है या नहीं है उस मैनेजमेंट के साथ, क्योंकि ये तो काउंसलिंग का स्टेशन है। उसने ये देखना है कि अपने आप को इंट्रोड्यूस करवाया, पेशेंट का नाम पूछा, ये बताया कि क्या डायग्नोसिस, क्या हाउ विल ही प्रोसीड, मोटी मोटी इन्वेस्टिगेशन, ये इजंट इट राइट। तो 3 स्टेशन तो हमने सॉल्व कर लिए। चौथा आएगा, जो तुम्हारी किताब तुमने बहुत मोटी कर दी। मुझे गुस्सा आया रात तुम्हारे कि तुमने ये किताब इन बच्चों के लिए लिखी है कि अपने बुजुर्गों के लिए लिखी है। 700-800 1000 सफ़े की किताब नहीं, वह इनकी कंजम्पशन के लिए तो उसमें से सेक्शंस निकालने पड़ेंगे। तो खैर वो है जो तुम्हारी किताब में बहुत इलेबोरेट लिखा हुआ है। वो अगला स्टेशन होगा सम इंटरवेंशन। सिंपलेस्ट कैथेटर डाल के दिखाओ, कोई भी इंटरवेंशन, वो फोर्सेप्स लगा के दिखाओ डमी पे, वेंटूज लगा के दिखाओ, एक्सटर्नल कैफेलिक वर्जन करके दिखाओ, एमनियोसेंटेसिस कैसे करोगी उसके स्टेप्स बताओ, सीवीएस कैसे होता है, ये दीज इंटरवेंशंस। इसी का हिसाब ना लो, या हो सकता है वो स्प्लिट होकर दूसरा अगला स्टेशन बन जाए। वो है ऑपरेटिव स्टेप्स। एपिजियोटमी की रिपेयर कैसे करोगे, 3rd डिग्री 4th डिग्री पेरिनियल टेयर को कैसे रिपेयर करोगे, उसके स्टेप्स। अब 4th डिग्री का टेयर वो क्या, उसको पहले आइडेंटिफाई करेंगे। ये यहां से शुरू करेगी, फेल हो जाएगी। शुरू करना है ऊपर से कि when I am told that is 4th degree perineal tear, what do I understand? What does it mean? फिर अगला स्टेप होगा I will confirm by inspection or जो भी by test। फिर जब डायग्नोसिस कंफर्म हो गया, फिर उसकी क्या इन्वेस्टिगेशन होगी, फिर एक्चुअल प्रोसीजर क्या है, लिथोटमी में होगा, डॉर्सल पोजीशन में होगा, फिर डाल के फिर एनेस्थीसिया क्या दिया जाएगा, फिर लोकल होगा कि जीए होगा, फिर एसेप्टिक मेजर्स क्या होंगे, ये कोई नहीं बोलेगा। ये शुरू करेंगे 3rd डिग्री या एपिसोड में, पहले मैं मसल बंद कर, वजाइना बंद, मसल बंद करूंगी, फिर प्रीनियम बंद, स्किन बंद करूंगी। फिर स्टेप्स ठीक है, लेकिन फिर चलो इंटरवेंशन हो गई, राइट। वो तो तुम्हारी जैसी चिड़ी एग्जामिनर होगी तो फिर वो चौथा आखिरी स्टेशन। लेटेस्ट इंफॉर्मेशन इन द सब्जेक्ट, कोई डेटा, मटर्निटी रेशियो पाकिस्तान की क्या है, पॉपुलेशन क्या है, इसी में वो जो 3-4 सब्जेक्ट तुमने अपनी किताब के आखिरी चैप्टर्स में डाले हुए हैं, रिस्पेक्टफुल मैटरनिटी केयर क्या है और वायलेंस अगेंस्ट विमेन क्या है, उसकी चेयरपर्सन हूँ तो जरूर पूछे। अगर ये बैठी ना इन्हें पूछ लेना जरूर पूछ।
सर एक अभी कोर्स हुआ है, उसके अंदर उन्होंने 2 स्टेशन कराए जेंडर बेस्ड वायलेंस के, एक जीबीवी का और दूसरा रेप का। और रिस्पेक्टफुल मैटरनिटी केयर, ये वाली चीजें जो है ये आजकल के एक्सपेक्टेड क्वेश्चंस हैं, तो इसके लिए तैयारी करके जाना।
तो वो तो कोर्स में तो थोड़ी सी बच्चियां होंगी ना, ये
हाँ।
तुम ऑनलाइन होके इस कोर्स में ये 2-3 टॉपिक्स जरूर अच्छी तरह कवर करो, घंटा लगा।
ठीक है, ठीक है।
मेरा पर्चा आउट हो गया, खत्म।
सर बहुत अच्छा पर्चा है वैसे आपका, मैं इम्प्रेस हुई हूँ आपसे। इसके अंदर मैं थोड़ा सा ऐड कर
अच्छा,
दूं। हाँ।
तो बड़े आज मुझसे इम्प्रेस हुई है तू, हैं?
सर मैं हमेशा ही इम्प्रेस हूँ। मैं पहले ही आपसे इम्प्रेस हुई थी। मैं आपको ये कहना चाहती हूँ कि जो इसके अंदर मैंने इसको 2 तरीके से देखा था। एक तरीका जिस तरह से आपने बताया, दूसरा ये है कि जो आरसीओडी का करिकुलम है ना, दैट हैज बीन डिवाइडेड इनटू मॉड्यूल्स। तो मुझे लग रहा था कि हो सकता है वो हर मॉड्यूल से रिलेटेड एक टॉक सेक्शन बना दें, वो भी हो सकता है। दूसरा तरीका जहां तक आप आए हैं, अगर इसके आगे मैं लेके जाऊं कि एक क्वेश्चन यूरोगाइनी का, एक क्वेश्चन इनफर्टिलिटी का, एक क्वेश्चन फीटल मेडिसिन का, एक क्वेश्चन जो है वो एंडोस्कोपी का, और एक क्वेश्चन ऑन्कोलॉजी का।
मेरी अप्रोच आपसे फर्क इसलिए हो गई, रुबीना, अगर हम इनको ये 5-6 स्टेप्स हर स्टेशन के बता देना
जी,
कि काउंसलिंग में ये 6 स्टेप्स हैं,
बिल्कुल
इंटरवेंशन में ये 6 स्टेप्स हैं, इस तरह से फिर इररिस्पेक्टिव वो फीटो मैटरनल वो चैप्टर कौन सा है,
कोई भी आए, हाँ ठीक है,
ये 6 के 6 कवर करेंगे तो हर एक का एक नंबर देगा तो 6 नंबर आ जाएंगे।
बिल्कुल बिल्कुल। और फिर जो नए इश्यूज हैं उनमें लेबर केयर गाइड आजकल बहुत ज्यादा वो हो रही है प्रोमोट, सो लेबर केयर गाइड जरूर आनी चाहिए। लेबर केयर गाइड सर मॉडिफाइड पार्टोग्राम है, जैसे पहले पार्टोग्राम था वो उसकी बजाय लेबर केयर गाइड,
मैंने कहा ना लेटेस्ट में तुम वो
लेटेस्ट जरूर आना चाहिए
कि क्या इम्प्रूवमेंट है, पार्टोग्राम की जगह क्या आ गया है, और मतलब ये उस लेटेस्ट उस स्टेशन की आखिरी स्टेशन की बात है, जो इनको किताबों में नहीं मिलता।
बिल्कुल बिल्कुल। नहीं सर, नहीं आप कहें सर।
तो आप ये जो आखिरी 2 स्टेशन है ना, इनकी बार बार क्लास लीजिए मई तक,
ठीक है ठीक है,
ताकि ज्यादा वो अवेयर हो जाए। हर एक हम जब 6 स्टेप्स की बात करते हैं, मैंने कहा ना इंटरवेंशन 6 स्टेप्स है, तो वो उसमें फीटो मैटरनल मेडिसिन का क्या है, क्या स्टेप्स हैं, और उसमें मैटरनल हेल्थ के लेबर रूम के क्या 6-7 स्टेप्स हैं, और गायनी के एंडोस्कोपिक सर्जरी के क्या हैं, और जेन्युइन स्ट्रेस इनकॉन्टिनेंस जो है वो उसके क्या स्टेप्स हैं, वो इंटरवेंशन के जो ये बताएंगी, जो ये बताएंगी, सस्पेंशन बताएंगी, वो टीवीएस क्या है, टेंशन फ्री, वो बताएंगे, क्या बताएंगे, वो उसके अंदर फिर ये समा जाते हैं, पास होने का चांस है इनका। तो चैप्टर वाइज की बजाय ये वाइज होना चाहिए।
ठीक है सर,
यू एग्री विद मी?
100% बिल्कुल एग्री।
क्योंकि एमनियोसेंटेसिस भी पूछ लिया, कभी इन्होंने किया नहीं, लेकिन वो 6 स्टेप्स में क्या है कि ये पहले इंडिकेशन उसकी मैं कंफर्म करूंगी, फिर उसके काउंसलिंग करूंगी, फिर उसकी तैयारी करूंगी, फिर एसेप्टिक मेजर लूंगी, फिर अल्ट्रासाउंड गाइडेड करूंगी, फिर नीडल डालूंगी, कभी पाई नहीं नीडल पर पास है।
ठीक है, थैंक यू।
चलो
Yes,
आज
sir,
तो
thank you very much.
थैंक यू फॉर स्टेइंग फॉर एक्स्ट्रा 15 मिनट्स इन माय क्लास।
मैंने क्या आपकी ड्यूटी बनाई है, फिर मैं अगली दफा इसमें पढ़ाऊंगी जो आपने बताया है।
नहीं, डू यू रियली एग्री विद मी कि
नहीं
ये
सर, I really agree with you and I think that if we go systematically तो इसको हम बहुत ज्यादा यूटिलाइज कर सकते हैं और ये बहुत अच्छा आपका थॉट प्रोसेस है। इसी को कन्वर्ट करेंगे टू एन एक्शन प्लान फॉर द एग्जाम। सो थैंक यू वेरी मच फॉर दिस।
चलो, और तुम ठीक हो?
अल्लाह का शुक्र, सब कुछ ठीक।